Good afternoon. Good afternoon, everyone. Okay, hopefully we still have some energy in today's session because we're gonna have a great lecture today. But first of all, I would like to say many thanks to Professor Rina Masada and also Professor Prihantono as the chairman of the surgery department and also as the vice dean for international affairs from the Faculty of Medicine for hosting today's sessions. And we also would like to say many thanks to all three speakers, great lectures. I see your CV and I'm really amazed with all your experience, knowledge, and yeah, many thanks for coming. And marhaban to University of Hasanuddin. Hopefully you enjoy our university. And of course, many thanks for all of you as the participants, the students, the residents from various departments. So for your information, we have many departments here from surgery, from head and neck department, and pathology anatomy. So there are many departments involved in today's sessions. And also we have from faculty of dentistry. So we have two faculties here attending the lecture. So as you know, our three lectures here actually have a scheduled operations in Wahidin hospitals. So they share their skills in the theater, in operating theater room. But we believe that they also have some knowledge that very important to be shared in the classroom. So that's why we invite them to have today's sessions. Okay, without further ado, I will introduce our first speaker, which is Dr. Abdul Malik Al Yahya. He is the consultant of maxillofacial and plastic surgeon, and he was graduated from King South University for Bachelor in Dental Science, and also he was graduated from University of Toronto along with Leuven University in Belgium. He received many many awards, invited in many conference, forum, and many international events. So we welcome you, and the floor is yours. Tafadal. Yeah, give a round of applause.
Very much. Thank you. It's Assalamu alaikum wa rahmatullahi wa barakatuh. It's really a great honor to be here in Indonesia. This is my first time. I had a few days in Jakarta and around Jakarta, and I flight here. I like the country. We have
Sorry.
two different weather, obviously. Here every time or every day you have a rain, and in my city in Riyadh it's very dry. So I'm very happy to be here, and Dr. Basim, I think with the organizers here, um, asked me to talk about virtual planning, and I usually give this lecture for virtual planning in orthognathic surgery or in facial surgery, but this protocol, this workflow applies to any virtual planning. So you can apply it in orthopedic, you can apply it in ENT, in any other specialty. And we are blessed to have the 3D CT scan, and from the CT scan we can take the patient skeleton and we plan many things around it. So before I start, I just want to explain some of the terminology that we have. So for example, you will see digital transformation or digital medicine, digital dentistry, and you will hear virtual planning, and you will hear CAD-CAM. So digital dentistry or digital medicine is everything that related to computer, and it involves many things. So virtual planning is just a small part of it. And CAD-CAM means the computer-aided designing and computer-aided manufacturing. And computer-aided designing is actually coming from the engineering side. It's not coming from the medicine side. And everything that you design in a computer called CAD, and everything that you manufacture using the computer called CAM. So in medicine and in surgery, we have the input coming from the CT scan, from the MRI, from the images, from many things. Then we put it in the computer, we do data processing, and we design what we want. What is the end product that we want from this CT? Then we manufacture it by two different kinds, which is either 3D printing or milling. And this milled, for example, plate, it can be in orthopedic, for example, or plate in the maxilla, and you use it directly on the patient, or you can do 3D printing to a guide that will guide you to cut in the proper place in the skeleton or in the maxilla or in the mandible. Okay? So I had the pleasure to be trained by Dr. Prof. Gwen Swinnen in Belgium, and he is the godfather of 3D planning in maxillofacial surgery. And if you look at this picture, I just want to give you just a basics. I know there is here expert people in virtual planning, but just want to give you basics before we start in the planning. So if you look at the picture, you can see that there is two people, but if you look closer, closer, and closer, it's only dots or squares, and these squares are the pixels. And in the 3D world, we have the similar thing, but it's a 3D box or 3D voxel. We call it voxel, which is the 3D unit of the what do you call it? The model that we have. So one thing also to understand in the basics that in CAD, in computer-aided design, we have two different areas. The first area is what we call parametric design, which means if I want to design this mobile, I will go with lines, angles, and curvatures. It's all mathematically correct. Okay, and that's why they call it parametric design. But if I want to design an apple, I want to design something that is not mathematically possible to do, which is the human body, we call it the biological shapes. I need to transform it to the parametrics in order for the computer to understand it. So if we take the CT scan, we actually have the pixels, some slides of pixels that will transform to a 3D. And if you see this apple, it's the similar thing. When we have slides, it will be transformed in 3D shape. So if we have bunny like this, I cannot draw this bunny by angles and measurements like the iPhone. So this is a biological shape. How can the computer understand the biological shape? I need to transform this shape into small units of parametric, which is what we call the vertices, or the voxels, which is small triangles. And this type of file, they call it STL files. And STL files is not a solid file, it's just a shell. So it's a shell with a very, 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 very thin cover. Okay? And if you scan the maxilla, for example, in dentistry, you will get the scan, the positive scan towards the teeth, and the other side will be empty, or the negative side. And in order to print this model, you cannot print the first one. If you scan it and went to the printer directly, the printer cannot do the printing. You have to give it a volume to print it. So we close it, we make it a solid, and then we can print it. And also, if you want to manipulate it when you cut it, you need to make it solid before you do that. And actually, it's very simple a program that I use, which is the Mesh Mixer. It's a free program. You can download it, you can play with it, you can have a sense of the CAD environment. I'm not sure if anybody had experience with designing guides or designing anything in the internet? Anybody? Anybody knows already what is CAD, AutoCAD, and the CAD designing? So if I am talking too fast or talking something deep, please let me know. I can slow down and explain it. Okay? So this program is a free program. You can download it. You can have any shape that you want. Then you can play with it and see what we mean by the CAD. So in order to have plan, so for example, let's say that I have a brain tumor and I want to cut directly over the brain, and I want to know the depth, I want to know everything. So now I need the virtual planning. I want to take CT scan of the brain. Then this CT scan, I will go through the workflow of this to put it, transform the CT scan, the DICOM data into STL, then the STL file, I can cut it, I can manipulate it, then I can do molding. You know, in the dental school, we have the dental impression, and when we take the dental impression, it's a mold of the teeth, then we pour it, then we have the positive one. This is the negative and this is the positive. It's the same thing in the computer. When you need to mold something over the brain, over the skull, you put a body, or you extrude this part, then you have a Boolean subtraction, then you will have a piece of plastic that fits exactly on the area that you want to cut, and we call it surgical guide. So the surgical guide can fit on directly on the bone, it can fit on the teeth, it can fit on the soft tissue, but the problem with the soft tissue, it's a little bit moving. So in order to have the virtual plan, you need to have this workflow. So in the clinic, we start in the clinic, we see the patient. Then we go to the studio, we take photos, we go to the X-ray, we take CT scan, we go to the lab and we scan our models, our impressions. Then we go to the office, we do the plan by the software, we cut and we manipulate, we can add and subtract. Then we print these guides into a biocompatible material, and we take this material with us to the OR. Okay, so who's here from dentistry? Dentistry, okay, good. You understand what I'm talking about. So it's a similar thing when we want to make, for example, a denture, or want to make a crown. So what we do is that we take impression, bite, face bow, radiographs, photos, clinical sheet. This in the CAD environment called the data acquisition or data collection. Then the pouring, the mounting, the model surgery, the tracing, the thing that we do with this data, we call it the data processing. And the transfer is like the surgical stent, the measurement that we do. And then we can take pre and post, and we have the CAD environment to tell you if you move exactly what you want. For example, in my specialty in orthognathics, we cut the maxilla and we advance it. So I want to take post-operative X-ray or CT scan and see if I moved exactly the same or not. And it can also, this environment can be used for education. So many universities around the world now, they don't have anatomy labs that we used to have. They have digital models where you can see the heart, move the bone. It's all in the computer, or sometimes in the augmented reality. So in orthognathics, the data acquisition is the CBCT, the intraoral scanner, or the impressions, the 3D photo, the surface scanner, and the clinical sheet, just to take notes. This is the program that I do the planning in. So I upload my CT scan, I upload the models, I do the occlusion of the teeth, and I upload the 3D photo and the skin of the patient. Then I start my surgery in the computer. Once I am happy with the surgery, Then I transfer this to dental splint, and I use this in the OR to position the maxilla. When I do the osteotomy in the maxilla or the mandible, we use it. So some of the things that you need to know is that the CBCT should be taken in the clinically accepted position. So if you are, for example, want to do the chin surgery, you cannot do this, the chin support, because the patient will come like this, or the chin will be cut, and you will not be able to do the surgery virtually. Whatever the surgery in the orthopedic or in the brain, the area of interest should be very clear and within the DICOM data. And also the artifact, if you have any metal artifact, some of the CT technicians will put a head support with metal, and this will block this area, for example. So you need to take care. The other thing is that when you want, so the CT scan is DICOM data. When you want to transfer this DICOM data to STL, to cut and to manipulate, you need to do something called the registration. And during the transformation, you have the bone threshold. And if you play with the bone threshold, you can change the 3D model. And also in the soft tissue, you can do that, the same thing. So now, when we want to take the teeth is a special thing that projects from the bone and has special situation. And if you have restoration or orthodontic treatment, it will not be clear in the CT. That's why we need to take it as a separate data. And either you can take it with intraoral scan, or with the lab scan. You take impression. So you do virtual thing, which is the impression and the model, then you scan the model, transform it to digital, or you go digital from direct by intraoral scan. I know it's a lot of information, it's a little bit boring, but the occlusion is very relevant to facial trauma and orthognathic. We want to put the teeth on the right place. So you have it in the cast, then once you are happy with the bite, you take a scan of it so you can use it in the planning. And we have also the virtual occlusion. So if you go with each step, I started doing the virtual planning since 2010, and every time we have a step in the virtual planning. So we used to take impression and we scan impression. Then we had the intraoral scanner. Then we used to do the occlusion manual, then scan it. Then we have now virtual occlusion. And I think down the road we will have everything digital. The face scanner, where you can take the face of the patient and you can see in a real time how this jaw will move. And actually they have a free software in the mobile that you can take a 3D photo of yourself, but we are using the facial scanner like this one. Okay, the data processing. So now we have the CT scan, we have the teeth scan, we want to put them together in order to manipulate them. So this process also called the registration, where you put the dental scan on the model, then you subtract it. So you have a very clear here scan with a very clear bone. Here it's very clear bone, but the scan, the dental is not clear. And during loading the dental scan, it's very important to understand the errors that can come. It's like when you take impression, again the dental people, when you take impression and there is air bubble, it will be positive in the model. So that's similar to it. You have error here, you might have something different, like the line is the true model, but the scan is above. So see, when I correct it, it goes back. to the same place. Also the head orientation. In maxillofacial, I want to move, the computer does not understand anterior, posterior, right and left. So you need to teach the computer where is the orientation of the head. So for example, if I want to move this jaw forward and the patient scan is like this, the jaw will move in this direction. So every STL file in the CAD has two information. The first information is the shape, and the second information is the position. So you need to put the position exactly in the right place so you move in the right direction. And of course, if you want to have an accurate position, you have to take a standardized photo for the patient. Then you upload this photo and make sure that the model is exactly like the patient. And during taking the photos, you need to have a vertical line so you know the photo is not like this, or the patient is not doing changing the position. So if you look at this photo, which one is the correct photo? You cannot tell, صح? But if you have a vertical reference, you can see that this patient, for example, is different than this patient, is different than this position. The last one is the correct position of the photo. So if I move the jaw using this photo, I will move it in this direction, but the correct direction is like this. So if the patient is doing like this, I want to move the jaw forward, it will go down. But if the patient going like this, I want to move the jaw forward to go up. One of the things in orthognatic and orthodontists that also when you orient the head, people with facial asymmetry will have the soft tissue different. The lip might be tilted this way or this way, and when you orient the head, you don't know where is the midline and where is the things. So if you see this patient, do you agree that the midline is shifted to the right? But once I corrected the soft tissue, the midline is on. So I want you to do an exercise. Everybody has phone. You can look at the front camera, and when you move your jaw like this, you see the midline is going to the other side. And this is because the soft tissue is distracted this way. And I think it's applicable to plastic surgery and anybody who works with soft tissue. This is also the correction of the midline. The segmentation means that you have a model and you want to cut it. So I want to cut the chin, I want to cut the maxilla, the mandible. We usually do this. And we cut the maxilla, we cut the mandible in the way. And this is how we do the osteotomy in real life. So we want to match it in the plan. So when we have the plan, we have a correct imagination or a photo of the patient. Okay? The center of rotation of the mandible is only relevant to maxillofacial surgery, and the rotation of the so again, the direction is very important. Also the point of rotation for the plan. So for example, if I want to move this maxilla in rotation, if I change the point of rotation to the anterior nasal spine, the maxilla will move like this. But in the program, if I put the point of rotation here, the maxilla will move like this. It's the same degree of rotation, but when I change the center of rotation, it moved totally different. The soft tissue picture is very good, but the distortion sometimes here and in the eyelid, because the eyelid is moving during the capture. This is one of my cases before and after, and you can see that it exactly replicates the post-operative photo. So this is before, this is after. You can see very good prediction of the soft tissue. But in cases where we have a long face, the lips are incompetent, if you do the planning, you see the planning is not very good, but because it's not very predictable when you have the incompetent lips. Okay, then in orthognathic we plan in 10 steps. This is part of the, I don't want to bore you with the steps of the surgery, but one of the things that, for example, this case, previously with the normal planning, we used to do it a single jaw, just advancement of the mandible. But when we see the virtual plan, she has a rotation like this, which is not visible to the naked eye. So we need to do the maxilla and mandible to do it. So final thing, how to take this plan and do it in the OR. You can do it with splint, the dental splint, or the surgical guide, the patient-specific implant, which is the plate itself, printed, 3D printed, or with the new technology like navigation. The dental splint is like this for the people who does not know how we do the planning. So when I cut the lower jaw and I want to position it, I put the splint, I put the patient on, I close the patient mouth, and I know that this is the position that I want, and then I fix it. Of course, one of the things that not only the guide, but you need to know the measurement of the cut, you need to know everything around it. Yeah, this is also not relevant. This is the surgical guide. So when you have, this is the surgical guide. So you put this in the beginning, you cut and you remove it, then you position the maxilla, and this screw here is the exactly same like this one, in the same position. And this screw is the same position as this one with the movement that you want. And so this is a titanium that you can use immediately. This is the surgical guide of the chin. So I design it in this way. So this is the cut. This is they call it teeth supported guide. So I put it on the teeth, then I do the surgery like this. So exactly where I want the cut to be, and use the saw to cut the chin. The navigation, I use navigation for dental implant only, and I think there is also navigation in the brain and the ENT. It's all the same technology, where you have like the satellite, like the GPS. The satellite and the car is your pointer, and the map is your X-ray. It's like Google Map. When you move the tip of the guide, it means like you are driving. So you see yourself in the map. Where are you? And you can see, like in this case, you can see the fracture, and you can reduce the fracture and make sure that the fracture is in the right place. You can move. This is the augmented reality, is that you put the image on a screen overlaying the patient, and when you move the maxilla, it will move in the screen. It's like, you know, Pokemon, what they call it? Game that was in the mobile a while ago. People were crazy about it. And also robotic surgery, I think it's also the future, where you plan the position of the maxilla, you attach the maxilla to the robot, and the robot will move towards the perfect position, the planned position. Then you just need to just fix it. That's it. And it was tried in China, but it's still under investigation. The evaluation is the same. You take pre and post, you superimpose, you make sure that you did the right thing. You can do the cephalometrics, the measurement of the airway. So as a final, the workflow of the virtual planning is data acquisition. So you collect all the data, then data processing, you do the cuts, you do the orientation, you do everything, then you transfer it into Splint PSI, then you do the evaluation. I'm not sure if you are interested in pre and post photos. Maybe the dental people will like it. But this is the accuracy of the CAD, the virtual planning, is that you have cases where pre and post. This is class 2 where the mandible was back and we advance it. And this is also gummy smile with class 2. We did the plan by computer, and you saw the prediction of the soft tissue. Again, class 3 patient. I think here in Indonesia class 3 is more than class 2, right? Or class 2 more than class 3? Yeah. With facial asymmetry also. This is the mandible is shifted in the left side. This is also class 3 with gummy smile. Class 2. You see, we did not do any rhinoplasty in these cases, yet the nose with the support of the maxilla was very good. Thank you very much.
All right, thank you very much for a great lecture. I actually really amazed with the result. The difference really significant from pre and post. Okay, we can continue to the next lecture from Dr. Jabir Muhammad Naif Al-Harbi. He's a consultant of otolaryngologist, head and neck surgeon in King Abdullah Medical City in Makkah, Saudi Arabia. He graduated from university in Saudi Arabia, and he also received a head and neck surgical oncology and macrovascular reconstruction fellowship from King Saud University in Riyadh, Saudi Arabia. And interestingly, he just received executive MBA from Prince Muhammad bin Salman College of Business Entrepreneur. Yeah, as I mentioned, he's the consultant of head and neck surgical oncology in King Abdullah Medical City since 2021, and he also founding director of Head and Neck Surgery Fellowship in Makkah Health Cluster since 2023. Okay, without further ado, the stage is yours, Dr. Jabir.
Thank you so much. First of all, Assalamu alaikum wa rahmatullahi wa barakatuh. I'm very happy and glad to be here. I feel home from first day. Thank you for the hospitality of all Indonesia. From the moment we arrived in the airport, the hospitality was amazing. And also, I'm actually working in Mecca. So Mecca is full of people originate from Indonesia. So I feel home. So today, when they called me for the lecture, I was thinking what things could be given to our dear medical students and senior people. So for the last 15 years of working with thyroid, so this is like brief about thyroid, just key points. So a practical clinical approach. So this is, I don't know if you can see the screen. No, screen is not there. What's the problem? Both of these has to be there. Wait, 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 wait. Yes, yes, I have it. They have it. Mm, yes, yes, first. طيب. أها. Setting a mirror. أيوه. أيوه. فين؟ هنا؟
هذه النكت ثانية، اضغط عليها. لا، هذه النكت ثانية. ليش ما ضغطت عليها؟ اضغط عليها نفسها
فين؟
تفتح. اضغط عليها. وين
أيوه.
الميرور؟
هذه هي.
اضغط عليها. اي اضغط على هذا ترى. كونكتد والله كونكتد.
Connected.
اي تشوز كونتنت. حط وش مكتوب تشوز كونتنت. هذه.
Okay, هذه.
ايوه غلط.
Yes, we are back. So I think you have a good break. So, so about thyroid. Thyroid, I think for the last few days I'm working with thyroids in the hospital. I was amazed with the cases you see, guys. It's a different experience for us. I think thyroid is very common disease worldwide. So this is Mecca where I work, and this is the Makassar University. So it's glad and happy. I'm honored to be here. And this is my hospital in Mecca. So not all thyroid swelling are equal. Thyroid is common, but some of them they are maybe deadly for the patients. So patients usually present to the clinic either with huge thyroid for the swelling. Swelling, they have large-sized thyroids, or they may have suspicious nodules. Since ultrasound is everywhere nowadays, they can detect thyroid nodules. So we are seeing increased incidence of thyroid cancer, not because of the disease increased, but because the detection was increased. Or they may be referred from endocrinology because of thyroid toxicosis. So by WHO, about 10% of the population have thyroid nodules. So I'm sure many people here, they have thyroid nodules. But only just 5% of them, they have maybe malignancy. Even thyroid malignancy, 90% are very good, excellent prognosis. So don't worry about thyroids. So when to worry about thyroids? When you have a thyroid swelling in very young age or very old age. Those patients, they have usually very bad thyroid tumors. In males, also if you have a family history of thyroid cancer, or if you have a radiation exposure or autoimmune disease. So as you study in the medical school, start with history, examination, investigation, and management. So what are the red flags when you hear it from patient or you see it in your exam? Family history, first degree relatives, okay? Not very far away family history, this is not significant at all. As we said, extreme age, very fast growing thyroids, this mostly very bad disease, anaplastic. Or a patient has thyroid swelling with hoarseness of voice, that means the thyroid is invading the nerve. Or patients have choking attacks, that means the focal cord is not moving. Or they have thyroids with lymph nodes, so this is mostly malignant. So in labs, we ask for thyroid function tests, but interestingly enough, we ask for vitamin D, especially those mostly going for surgery, because risk of hypoparathyroidism, post-thyroidectomy, total thyroidectomy, will become very bad if the patient has hypopara and very low vitamin D, which is very common disease. So you start correcting the vitamin D right away from the clinic because it takes time. Literature, you will find a lot of studies showing the significance of correction of vitamin D before doing thyroidectomy. So please, whenever you think this patient is going for surgery, correct vitamin D. Ultrasound is the gold standard radiological workup for thyroid. Why? It's very everywhere. No radiation. You can do it in the clinic. Surgeon can do it. I encourage every surgeon to do it in their clinic. You can do FNAs in one visit. You can even do RFA in the same setting. So ultrasound is the gold standard. So for thyroid, we like ultrasound. Outside the thyroid, we like the CT scan. So if you think this thyroid is going outside the thyroid, do a CT scan. Also, the American Radiology Society, they have the very well-known classification of thyroid nodules by ultrasound, the thyroid system. So they classify the thyroid nodules according to their suspicious rate. So, so to be a common language between radiologist and surgeon and endocrinologist, so the thyroid 1, which is a very benign, thyroid 2, thyroid 3, up to thyroid 5. So the more thyroid is the more risk of malignancy and the more need for biopsy. So every thyroid ultrasound should be graded by the thyroid system. So not to mention just hypoechoic size, etc. It should mention the size and the thyroid and the location of the nodule itself. We don't do CT in every patient except in special situations. When you have thyroid going just behind the sternal notch, or if you have malignant disease, if patient already did surgery before, so you want to really assess the thyroid and if there is any remnant or there is lymph nodes, or a patient has huge swelling. Also, the importance of doing contrasted CT scan of the neck. So please, whenever you ask for CT neck, it should be with contrast. This is a patient, if you see in the right side, a CT neck without contrast, you can see the airway, you can see the bones, but you cannot see the vessels. Okay? If you see in the right side, this patient did, the same patient did the CT neck with the IV contrast. You see the carotid, it is encased within the thyroid. So if you do thyroidectomy in this patient, you may kill him. So CT with contrast is very important. So CT without contrast has very little value in evaluating thyroid and lymph nodes. This is the video of the same patient doing with IV contrast. Will show a lot of details. You can see the great vessels, the lymph nodes, if there is any invasion to esophagus and trachea, etc. Also, as we have a very common terminology between radiology and surgeon and endocrinology, we have a common terminology between us and pathology. We like to speak the same language, not to say a lot of medical terms and then we get confused. So there is a classification for FNA of the thyroids, which is the Bethesda classification. So we have 1 and 2 up to 6. 1, there is just no diagnosis, no cells, no thyroid cells. And 2, when there is a very benign thyroid cells. And Bethesda 6 is malignant. So the risk of malignancy is very high in Bethesda 6 and very low in Bethesda 2. So this is give you what type of surgery you're going to proceed. So management of thyroid nodules, observation for very low risk thyroid, very reassuring Bethesda either 2 or 3. You may do total hemicompletion or ethanol or radiofrequency. So when we do just hemithyroidectomy, you have one nodule on one side and the other side has no nodules. Or even if you have a malignancy in one side and it is less than 4 centimeters and there is no lymph nodes and there is no extrathyroid extension, you can just do hemithyroidectomy. So you could do hemithyroidectomy for papillary thyroid cancer if it has confined to one side of the thyroid, has less than 4 centimeter, and there is no extrathyroidal or lymph nodes. When you do total, when you have more than 4 centimeter, even the other side is normal, you have to remove it. When you have lymph nodes, when you have extrathyroidal, and when you have a distant mets, when you have very huge thyroid, you have to remove all the glands. And sometimes we do diagnostic, either hemi or total. When we do completion, if you do one side and you find a very bad pathology, either tonsil variant or columnar variant, very bad variants, we know they're very aggressive, so you have to do completion so patient can receive radioactive iodine. And if you have extrathyroidal or lymph nodes, etc., or mets. Either neck dissection, usually in cancer, we do either prophylactic or therapeutic. Therapeutic when you have positive cervical central lymph nodes. Prophylactic when you have a very high grade extrathyroidal, and you do it central as well. And usually you do level 1. I'm not familiar, I know if you're familiar with the levels of the neck. Usually we don't do level 1A or 1B or 2B. We don't do it. Very rarely, unless there is any lymph nodes there. So we did history and exam, workup, FNA, and surgery. So after surgery, we like to stratify our patient, either they are low risk of recurrence or intermediate or high intermediate or very high risk of recurrence. So this will decide, shall we give any adjuvant treatment or no. So this is from the last American Thyroid Association guideline, just published a few months ago. So after surgery, you can stratify your patients. And according to that, you may give radioactive iodine or not. So if you do thyroidectomy, usually it's a very safe procedure. The risk of complication is very low. And literature shows that the high volume surgeon, they have very low risk of or incidence of complication. The most common complication is hypoparathyroidism. It's like about 25% of patients gonna develop hypoparathyroidism. So in every 4 we have one patient. So the half-life of PTH is minutes. So if you do 1 hour testing, it will show up this patient may develop and give you very high prediction if this patient will have hypocalcemia because of hypopara or no. Usually the calcium take 1 to 2 days to fall down. So if you follow calcium from day 1, calcium will be normal in day 1. But if you come in day 2 and day 3, patient will have symptoms of hypocalcemia. So before that, you can catch up the hypopara by doing PTH if you have it. Also, we ask for magnesium level whenever we have hypocalcemia. Have to be corrected simultaneously. Okay, so when to give IV calcium? Whenever patient have hypocalcemia symptoms, either clinical or by ECG, or the corrected calcium is less than 7.5. So my last slide is the home message. So all thyroid ultrasound should be reported using the thyroid system. Not all nodules indicated for FNA. Actually, the last guideline says even very high risk nodules by thyroid, less than 1 centimeter, don't do anything for it. Okay. Not all nodules need surgery. Even in some cancers, lobectomy, just removing one side is enough. Radioactive iodine depend on the post-op risk stratification. And we usually take the whole picture. This is like a puzzle. You take some information from history, some information from exam, and from the lab, and images, and you collect it together. So you share the patient in the decision, and then you either go for observation or hemi or total thyroidectomy. So it's like a puzzle. You take the maximum information from everything that you gathered, history, exam, and workup, and then it gives you a very good insight about your decision. And the last slide is this is the last, actually we are following the North American guidelines. So we are following the 88 American Thyroid Association guidelines. But I encourage everyone to have their modification. This is a guidelines just to help, but not to decide for your patients. Thank you so much.
All right, thank you so much for the great lecture. So we actually still have one lecture from Professor Basim, but I believe he still have operations in the hospital, so we will move on to the Q&A session. So for this Q&A session, maybe I will invite two of the speakers to the stage. So for all the participants, if you have any questions, please raise your hands and you can talk directly to the lectures. Any questions? I actually have very general question. First of all, what's your impression about Makassar and Indonesia in general? Because I believe this is your first time coming here, right?
Yeah, so actually, in Makassar, my experience is all inside the hospital. Because I came 2 o'clock
AM.
a.m. and I immediately came in the morning to the hospital. And yesterday, and the last day from the hospital to the hotel, I almost slept all the night. Then I came back here. But I had a few days in Jakarta, and I really liked it. And you have a very beautiful country, very beautiful sightseeing. And I went to the zoo.
Oh,
Yeah.
yeah. Did
I
you see
had
the
a few
Komodo?
days, yeah. Huh?
Did you see a Komodo?
Yeah.
This is a very specific animals
Yeah, yeah,
coming
yeah,
from here. Yeah.
yeah. So thank you very much. And, as
Yeah.
Doctor said, since the moment that we arrived here, everybody was very generous. Everybody was very good with us, and I really appreciate that you invited us here.
Sure, sure. That's our ethic to treating our special guests. So maybe from Dr. Jabir, as you spend so many times in the hospitals here during in Makassar, maybe what's your impression about the hospital, or maybe the case that you're working on in the hospital here? Maybe there's a difference comparing in Saudi, or what is your thought about that?
Regarding the operative setting,
Yes.
it's almost like Saudi Arabia.
Okay.
Actually, we are amazed with the facilities that you have,
Mhm.
the technology that you have. You have the high-end instruments and facilities. So I think everything is there available. And you have the population and very high volume, I think a very
Yeah.
high volume center.
Yes.
The type of cases, actually in Saudi Arabia, we see not huge thyroids. Here we see a lot of huge thyroids. I don't know, maybe that's why every geographic area is different. But here we saw, we are amazed with the cases that we saw. I think you have much better experience than we have in regarding that cases. And everything, there is always potential for improvement in our center and your center. And what's really I like, and I was amazed with the hospitality that everyone has. People staying very late in the night and they're still smiling and they're still helping. And even they're coming to us, you need anything? We can help with anything. I was really amazed. The hospitality, even I spoke to Mujahid, people here, like من أهل الجنة ما شاء الله.
Alhamdulillah. All right. Is there any questions from the floors? If you have any questions, please raise your hands, because we are waiting for that.
I'm sure my presentation was very clear. Huh?
Yeah. Yeah. Tafadhal. Silakan.
in the last decades, there is a popular of tutfa, and in the last few years, the popular of radio frequency ablation and also microwave ablation.
Ablation, yeah.
We have
Radio
the
frequency,
device
yeah.
in our hospital. What is your opinion about the minimal invasive in thyroid surgery?
Yeah, I think it's coming to EVA, the endoscopic transoral thyroid surgery is coming, but it's usually for the small thyroids. Is not for the huge thyroids, and also we don't like it for malignancy. So for benign, yes, I think it's doable, and it's everybody start to adopt it because thyroid nodule most commonly in females, and females they care about the scar. They don't like, they want scarless thyroidectomy. So I think it's coming. So I encourage everyone. I'm start taking courses for that. Also, radio frequency is coming as well. So people trying, especially if you have, it should be benign nodules. So for benign nodules, I think yes, you can do radio frequency, especially surgeon. They know where is the nerve. They know they can see the patient, so they can help the patient in one setting. So I think those technologies are coming, and people start knowing about them. And as we go, we'll have less and less traditional thyroidectomy.
Thank you.
Okay, thank you, Prof, for the questions. Is there any questions from the floors? Maybe one question from me regarding the kind of software that you show, how you prepare the virtual plan, something like that. Is there, do we need a specific training for that, and whether that software can be used widely? I mean, for example, here, can we use that kind of software as well to perform the virtual plan, like what you did?
Yeah, so the CAD softwares, they have two kinds. The general software like Blender, like AutoCAD, like Mesh Mixer. It's a general software that you can do anything. They are manufacturing chairs, they are manufacturing things like this. So you do the design, then you can take it to manufacturing. But there are also specific softwares for the surgery. And you can do, for example, fibula and put it here. You can do, and it's only a preset module. So in the regular software, you would do the fibula in, for example, 20 steps. You will do the segmentation and you move it, and but the specialized software, they have an AI where you just click one click and it will segment the fibula for you. Then you can have overlap. They can put the jaw and the fibula together. Then you move the fibula and you see how does it fit. So all of these specialized software help you to have a fast surgery. But I used to do the whole plan on Mesh Mixer. Mesh Mixer is a free software. So you can take the DICOM, transfer it to STL by also free software like Slicer, and then take the STL to Mesh Mixer. Then you can cut it and you can make some guide. I really have a photo that I put it in Instagram. So I had like an electric box in my home, which it was blocked. Then I had a camera installed, and the cable of the camera, the cover of the box did not fit the box anymore because of the cable. So I just scanned the cover and I put it in the program. I drilled a hole in the virtual. I just make a hole for the cable. Then I printed the cover. Then I put it back again with, it was like this cover with the cable hole. So these things are doable by the free software. And Yeah, I think it's a learning curve where you need to start playing. Everybody now is playing games and familiar with the environment of the cat. Then step by step you can make a microphone, you can make a box like this. Then you go and understand how to cut, how to subtract. It's like Photoshop, but for 3D.
3D.
Yeah.
You use it in oncology?
Yeah, we use it as a guide, especially if you have, for example, when we cut the condyle and the maxillary artery is just behind us. So we want to cut, we don't want to waste our time cutting with bezo or small or drill, and we want to protect the artery. So we make the guide cut until it goes through the cortex, then the guide will stop you. And you can continue the cut with the osteotome, which is very safe for the artery.
This is for the bone. What about soft tissues? Any?
Yeah, yeah. The soft tissue, I think it's the problem with soft tissue. It moves. So if you put the guide here and it moves, unless you fix it, like in the brain surgery, they fix with a screw the stylet of the navigation. Then they do the plan based on the bone and use it for soft tissue.
So everybody using 3D printing.
Yeah.
It's the same idea.
Everybody has a 3D printer. No?
No, not everyone.
There is a very cheap 3D printer in AliExpress.
Yeah, that's very fascinating. Is there any question from the floor? Yeah, please, doctor. Yeah.
Thank you for your presentation. I will ask about the virtual planning. My question is, in your presentation, there's no cephalometric analysis. And my question is, are we can replace the cephalometric analysis with 3D planning, skip to 3D planning without cephalometric?
100%. So I always say that, one of my friends, he went to a tailor in Sudan. You know the thobe of Sudan? So it's a very fluffy thobe. And the tailor looked at him like this and say, okay, you come after 3 days, I will make you a thobe, which is the dress. And he said, you did not even measure. He said, no, don't worry, I will do it. Then he came back and the thobe was perfect, just by looking. The idea is like this. So if you have, if you want to do, for example, a shirt, you will measure from here to here, and they will take measure here and that. Then they will take these numbers and go to the fabric and do this. But imagine if they can take a scan of your body, then they have a mannequin, and this mannequin, they don't need to measure. They just need to cut over the mannequin itself. So the 3D model is like a mannequin. So we have the patient itself. So when we move, for example, I move the midline of the maxilla until it's in the midline of the skull, and that's it. Maybe you tell me how many millimeters you move. I said, I don't know, because I move it until it's right. If we have today, we did a hemifacial microsomia. It was a case with severe cant, and when you move the maxilla, you move it until it's parallel with the floor. Previously, you measure it on the cephalometric, and you know how many degrees, but now you can see it that it's flat. If I tell you, for example, this box is tilted like this, please make it even. You will measure? No, you'll just do like this. It's okay. Because of the pleasure that we have with 3D model, you can see it in the same time. So I don't usually do the cephalometric anymore.
Thank you.
So it's kind of a way to not doing that, right? I mean, if you are doing the 3D, it means you don't need to do the measurement anymore. Yeah, that's great. All right, is there any other questions from the floors? So for your information, we are still waiting Professor Basim. He's on the way and he's very close to us right now. Maybe he's almost arrived. So, so you're gonna leave? No? To the hospital. So we actually want to have the photo sessions together. So maybe we can actually when so
If you are interested, I can show you how I do the plan in the few cases that we have.
sure.
Okay, so this is the original data. I'll just show you the CT scan. So this patient had hemifacial microsomia, which is under development of the left side of the face, and there is no proper condyle. If you can see from the other side, this is normal condyle of the mandible and normal chronoid, but she had underdevelopment here, and as a result of that, she had severe asymmetry. When you have the midline, if you move the midline in the middle of the skull, you see that this is the middle of the chin. So what we did today is that we did a maxillary osteotomy, mandibular osteotomy, chin osteotomy, then we tried to make the face straight. So I go with the same. I will not try to repeat, but we uploaded all the data. We uploaded everything. We can change the face from here. Let me just do that. Yes. So from here I can change the skin, for example. I can upload the 3D photo. Maybe I'll show you one of my cases in Saudi Arabia with the 3D photo and how we move them the jaw. Okay. So what we did is that we did osteotomy. Osteotomy of the maxilla, osteotomy of the mandible. So what we do is sagittal split on the mandible. You see this bone, we moved it down. Then we do a Lefort 1 osteotomy, which is moving the jaws, then genioplasty, and we rotate the genioplasty to have a straight face. So you can see in the soft tissue now, she had a straight face, but here she has a tilted face. And you can see it in the bone, like this, and this area we used to do bone graft here, so it will heal nicely, and we fix it with 2 plates, and here 1 plate, 4 plates in the maxilla. Okay, I will show you how we do my private cases. For example, please don't take a video or photo, huh? This is a private patient. So, for example, you can have this 3D photo. And you can see this is before the surgery. And this is after. No, this is just a virtual plan, yeah. We do CT scan again after the surgery, and we do 3D photo, and we make sure that they have the same results. But this is just to show the patient what's happening. And this is a very realistic photo that you can see. And you can see it from all the sides, like this, okay. And this is one of the program. You can export from here, and then you can go for what I call the mesh mixer. Is this program. So I use this program. This is the slicer that converts the CT scan into STL. And this is Blender. Everybody knows Blender. It's a free software that you can do many things. And I have Autodesk, AutoCAD Fusion for the parametric design. But this is my favorite software, which is the mesh mixer, and it's free. It's very simple, and you can see videos in YouTube how to do things. But for example, if you want to do something, for example, this is the bunny. You want to do a surgical guide for the bunny, for example, or you want to do surgery. So you go and select the part that you want to cut, for example. Okay, then you can go and cut, discard. Now you have a hole. Then if you want to fill this hole, you can take, for example, one of the shapes, the regular shapes that here. You can put it here, then move it around. Then when you are happy, you can accept. Now if you want to cut this box exactly over the bunny, you want to make like a positive and negative thing. I need to make this solid. Okay, accept. Then wait, transform. Cancel. I'll make another bunny. Sorry, I just. You see, half of the bunny is inside the box and half is outside. When you are happy like this, you can I'll just make the bunny solid. Accept. Okay, now I want to cut the bunny from the box, or you can cut the box from the bunny. Okay, but it's better to cut the bunny from the box. So you select first the box, then you select the bunny, then you have a Boolean either subtraction or addition, or if you want to fuse them together, if you want to cut the first from the other. So I do a Boolean difference, and you can see now the shape of the bunny inside the box. We just cut it. Okay, we do accept. If you print now this one, you will see you can have the bunny and you can fit the box on it. So if you have the CT scan of the patient and you want to fit something here, you can bring the box and put it here. Then you cut the patient from the box, so the box will fit over the patient. That's the idea of the virtual planning. And in parametrics, if you don't like this, for example, so this is, they call it the Boolean operation. So it's operation cut and move. But if you are artistic, who does like drawing? Who's artist here? Who like drawing and sculpturing? So if you like it, you can use this sculpt, this tool. Then you use, for example, you can move this. You see, you can sculpt. You can either use a positive or negative, like a positive like this or negative like this. If you want to pull this corner, you can pull it like this. You see, you can make very funny shapes with it. But if you want to use it in medicine, the primary shape that you want to try and cut and do is the skull. In my case, is the skull and teeth, the face. But it's very funny to use this software. If you master this software, Mesh Mixer, I think you can do anything. And by the way, the people who does this, how much do you think they charge us for the fibula guide and for the PSI? Huh? No, 1,000. In Materialize and KLS Martin, they charge over $30,000, 30 for a bare one case. So if you master this planning and softwares, you might have a job for life. And you don't need to practice medicine anymore. Okay, Dr. Bassem is here. We're just playing with 3D.
Okay, because we already have Professor Bassem here. Welcome to the Hasanuddin University. Maybe before we have Professor Bassem, we would like to invite Professor Rina Masada to welcome all our speakers and also to give some speech to all of us. Yeah.
Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh. We already have two speakers, and I believe that it's very interesting and they enjoy the lecture today. So I would like to say thank you very much for our speakers today. For your sharing of knowledge and skills. And we have here is the students and also the lecturers from Department of Surgery, ENT, and also from Pathology, and also from Faculty of Dentistry. So I know that you are very busy of the operation. Professor Pri already told me that you have like many patients, and I know that it is very special cases for head and neck surgery, and also for your sharing of skills for our residents and also our lecturer. All right. So The next step is we want to, so this faculty is already, we have many collaboration around the world, we mostly from Japan and also from Europe, but for the next steps, beginning of the next year, we will make a collaboration with the Arabic countries, because we know that more convenient also for Indonesian patients, yeah, because they know that the Muslim people will do the operation for me. So mostly patients feel like it's very good, very convenient. So yeah, we will. So I will contact your university and your hospital to do the next collaboration with. Okay. Thank you, and also enjoy for the last speakers. Assalamualaikum warahmatullahi wabarakatuh.
Okay, the next session is because two of our lecturer gonna leave, so we will have our photo sessions together. So yeah, maybe we can stand up. All of us can stand up, and the yes.
Ya, tapi dok bisa agak ke tengah-tengah sedikit dok. Ya,
Ya, masuk saya, masuk. Okay, the next session is because two of our doctors gonna leave, so we will give some certificate for thanks to them. So we invite Dr. Jabil and Dr. Abdul Malak, and then we also invite Professor Rina and Prof. Pri Hantono to give the certificate from university and a souvenir from the University of Hasanuddin. Iya, memang Prof. And then, yeah, please. Okay, once again, let's give a round of applause to two of our speakers. Thank you very much, and hopefully we can see you again. Thank you very much. Waalaikum salam warahmatullahi wabarakatuh. All right, so we're going to move to the third speaker, which is the Professor Basanti Jamal. He is a consultant and also professor for oral and maxillofacial surgery department at King Abdul Aziz University. He leads so many organizations, both in national and international level. He also presents studies, insight approach in many national and international international events, along with publish so many papers internationally. So without further ado, for Professor Basanti Jamal, the stage is yours. Tafaddal.
Assalamu alaikum wa rahmatullah. Bismillah ar-Rahman ar-Rahim. First, I'd like to thank the university for the kind invitation. Thank you, Doctor, for the opportunity for us to discuss with your staff and your trainees some of the background that we have in this camp. I really would like to thank them on behalf of all the group for their collaboration and support for the camp, which was going on for the last few months. So thanks again. It was really a pleasure having a chance to work with you, and it's a pleasure to speak here at Hasanuddin University. Learned about Sultan Hasanuddin, and it's quite an impressive biography. So it's a pleasure to be here with you. So that I will not take much of your time, I will get started, inshallah, with my topic. So the topic is, didn't show up. Like, by the time that I connect, for the time's sake, I will just get started, inshallah. So the topic, as you saw, was update on oral cancer. There's so many different points that we can discuss. Okay, just like that? Yeah. It's different. Okay. One of the points that was really something that we just updated and reviewed recently was the management of the N0 neck. I know there's oncologists here, but I also know that there are others who are not from the oncology background. So I thought we will just mix some of the information so that it will be something that will be valuable, inshallah, for everyone. And even if time didn't allow to get to the last point, I'm fine with that. But when we talk about oral cancer, really, we should cover all these points. Starting from the survival, I think it's the most important to address and to discuss in any disease that you're dealing with. Not just survival, even morbidity. How does that disease affect the population? Then going through the items and the points that you all know, and I will go over it briefly. I will just give an idea about some of these points. And as I said, inshallah, it will be something that will be beneficial to some degree to everyone here, regardless of the background. One aspect about oral cancer is that the majority of cases are squamous cell carcinoma. We don't have a lot of other entities, though. Most of the cases are epithelial squamous cell carcinoma. Next to it comes salivary gland cancer, but then the others really constitute a very small minority of cases. So that is unique to oral cancer, squamous cell carcinoma, because then most of the cases really fall under one category. There's no wide variation among the carcinoma cases. As I said, just the first thing we want to discuss is to understand the survival. And I will touch on this on different cancers as well. I know breast cancer is the most common here in Indonesia. It's the most common in Saudi Arabia. I don't know, do you guys, it's a question to the trainees. What is the 5-year survival of breast cancer? Anyone knows roughly? Of course, the oncologists know that by heart, but the other specialties, trainees, students, what is the 5-year survival of breast cancer? It's about 91%, at least that's the generalized literature. So what is it for oral cancer? It's 40 to 50%. So we're dealing with a cancer, that's just the first information that everyone needs to know. It's a much more aggressive cancer than most other cancers. Yes, it's not as aggressive as pancreatic cancer or lung cancer, but it's a very aggressive disease. And as you can see, obviously on the curve, the 4 stages, as the stages advances, the survival drops even to 25–30%. And the problem here is that, I was talking with Professor Pri, the same applies to my country. Most of the patients present at a very late stage. And I will show some numbers regards to that. But this is some of the paper systematic review that was published. As you can see, most of the, in Saudi Arabia and almost all the cases are presented at an advanced stage, and I will talk about this later on. Why does that happen compared to other areas in the body? The reason is that really there's low awareness about oral cancer, because everyone gets oral ulcers. A lot of people have oral ulcers, so they attribute it to something they ate or some kind of reaction they had up until something gets bad, and up till after a few months, and I just said how aggressive the disease is. So spreading awareness about oral cancer really saves lives. I don't know if time will allow to discuss some of these things, but it's very, very important. And I believe in the university you must have some of these camps every now and then to spread awareness. This is one area that is very important for us in our field, especially the maxillofacial surgery profession. And some other factors, all the way to the fear of the stigma from the surgery. I know, alhamdulillah, maybe in our countries we don't have suicide as much as in some other countries. But in the Western literature, the highest suicide rate is among head and neck cancer patients compared to all other cancers, because it's for a very obvious reason. All other cancers the patient can hide, not the head and neck cancer, not the oral cancer specifically. And there's another important fact here which really very clearly apply to us. This is a paper at the beginning of the century that reviewed diseases from the previous century, over 50 years. There was a decline, 67% decline in mortality from heart disease, 77% decline from cerebrovascular disease, 66% from pneumonia, influenza, and other infections. But how much improvement happened in cancer? Just 8%. Please notice that in that century there was a significant improvement in leukemia and childhood leukemia specifically, and lymphoma. Despite that, oncology showed the most minimum improvement in survival from the previous century to the beginning of this century. So we're dealing with something that is really very aggressive, affecting not just the patient, as you will see now. I will talk about some other aspects, but almost everyone in the society, as we will see. The epidemiology ranges or varies from one country to another. I'm not going to talk about that, but in Saudi Arabia, oral cancer is the most common, sometimes nasopharyngeal in some regions. However, we have a higher incidence of oral cancer compared to the other Gulf countries, specifically in one area in the country. And I'm sure if you know your literature, you'll probably find something similar. In the literature, advanced cases are discovered in about 53 to 62% of the patients. Let's say 50 to 60% are diagnosed at an advanced stage. In the two institutions where I work, it's about 78 actually to 88% in the most recent review. The majority of patients present to us in an advanced stage, as I believe is the case here as well. And that's important to understand the literature. I'm sure the trainees here, you go through sessions of analyzing everything in the literature. So Memorial Sloan Kettering, very famous name, right? Professor Pri, I'm sure everyone in oncology knows it. Famous worldwide center that deals with oncology. What's their 5-year survival of oral cancer? It's 65%. It sounds very impressive, but you just have to go through the details of the paper. How many advanced cases they had in that paper? Only 25%. If they had 80, 85% like you and me, probably it will end up being the 45 to 50%, like what we're dealing with. So diagnosing diseases early is really a key component. How about nodal disease? We all know that having nodal disease drops the prognosis by 50% in oral cancer, probably in other cancers as well. So nodal disease in the Memorial Sloan Kettering was in roughly 30%. For us, it's in roughly 60% of the patients. So that's just one thing to understand about oral cancer and cancer in general. But before I conclude this point, I just want to emphasize the concept of the economic burden. Economic burden is a key factor of healthcare. I know for trainees now, our focus is on helping the patient, relieving the pain, treating the disease, addressing all the needs of the patient. That's important, for sure. That's definitely our first goal. But on the national level, understanding the economical impact is very important. It's not just the cost of the disease, or the cost of the medication, or the cost of the hospitalization. It's the cost of the loss of productivity from that individual, as you know, on the society. So looking at the literature without going into the details, it's 2 times to 5 times more expensive to treat these diseases that we're treating in the advanced stage compared to diagnosing it early. Of course, more importantly is the 5-year survival, of course. But the economic impact is not just on the national level. It's on the family itself, who's going to lose the productivity of that individual, and maybe even lose that individual because the survival is going to be affected. So it's on every level. Understanding cancer in this perspective and more, as we will discuss, is very important. Risk factors, I believe it's the same worldwide. Tobacco, alcohol, smokeless tobacco. We have something called shamma, very prevalent in some regions. Basically like smokeless tobacco, it's definitely associated with increased level of cancer. However, we don't know most of the origins of squamous cell carcinoma. So I'm going to skip this really, but just one piece of information: tobacco increases oral cancer by 8-fold. 8-fold is 800%. It increases lung cancer by 25-fold, but it increases oral cancer by 8 folds. Smokeless tobacco in our country increases it by 25 to 30 folds. I don't know if they use this here. I believe some regions they use it. Sometimes the product is very carcinogenic and the risk is much higher. There's other important factors to keep in mind, which is, let's call it clinical risk features or clinical risk factors. So for us in oral cancer, if there's numbness or weakness in the nerves, any infiltration of the nerve is a bad sign. Infiltration of the skin is a bad sign. Even weight loss. I took this photo once from a lecture that grabbed my attention. I'm not getting it from any textbook because I really want an idea to stay with everyone, that with 40% weight loss, that's almost no one is going to survive that, no matter what we do in oncology. We don't see patients at that. If the patient lost 40%, most likely we cannot operate. But even from 10%, survival is compromised, and morbidity and wound infection is compromised. So paying attention to the weight loss is very important. I'm going to skip some points to just be able to talk about as much as I can. And maybe this is a piece of information for even the trainees. Knowing the complications is part of the spectrum. Of course, I'm sure you know that. But why am I saying it? Because we have trainees as well. And sometimes I know you're so excited about understanding the profession that you're dealing with that sometimes you go to a very advanced level in your reading or in your focus. So I just wanted to emphasize here the ladder that you go through. So your basic science, especially for the first year, I guess here you call it first semester, second semester level, you really want to go back to your basic, which is anatomy for us. You cannot do anything later on without building on your anatomy. Then knowing the information of the disease, whether oral cancer, benign disorders, salivary gland disorders, etc. Then the technique, because most of the trainees get stuck on the technique. They want to know how to do the procedure. They want to write down how to do the steps. They want to do more of the procedure, which is where most people get focused. However, the 2 levels before are important, and the 2 levels after, which is complication and alternative techniques. So you don't want to focus on these things before you master the basics in the beginning. So what are the complications of oral cancer? And that's important even for general practitioners, is that if the patient got radiation, that patient should not undergo any oral surgery, not even an extraction, except by you know, the experts in the field, maxillofacial surgeons, oral surgeons, they should be referred to them because there's specific points that can be done, including giving the patient pentoxifillin. It's like a vitamin E, basically, for a couple of months before. It reduces the risk. I know most of us know the hyperbaric oxygen. It's a big controversial topic for us. There's so many papers showing that it doesn't really help. It's very expensive. So we really cannot offer it to every patient. So it's not necessary according to the literature. There's a simple drug that can be given for a couple of months before a procedure is done that prevents patients from going through this. This was a cancer patient from 15, 20 years before when he developed this osteoradionecrosis and came to us. And the suffering he had from osteoradionecrosis is almost as bad as the cancer. So look at the resection. It's almost like treating cancer patient, similar to what we're doing now with all the cases, the flaps and the reconstruction. So we want to avoid that. So yes, avoiding complication is key component, which in oral cancer is something simple. Just those who are didn't hear the pentoxifillin before, please review it, be familiar with it. Something that can really save the patient a lot of suffering. Yeah, we don't consider cancer cured until 5 years, right? So that's why we really kind of build this very strong relationship with the patient and their family, because we get to see them for a while. There's no exact guidelines on the follow-up, but there's different variation between every system, every department and unit, hospital have their own protocol, how frequently to follow and how frequently to get images. So I don't want to confuse you with that. But we usually see the patient very regularly, every 6 weeks to 2 months in the first year. Why? Because 80% of patients in oral cancer, and that's unique about, again, this cancer compared to other cancers, most of the patients who will have recurrence will have it in the first year. I just told you we have lower survival compared to other cancers, right? Most of those who will have recurrence will have it in the first year, 80%. So we really need to keep a very close eye on the patient in the first year. And I like to call it wellness anniversary to the patient. Every time the patient comes to the clinic who have cancer is afraid from what the doctor will tell them. Even the blood investigation. They are concerned if the hemoglobin will show something that shows cancer. So once we pass the 1 year, we congratulate the patients. It's really a big deal. We celebrate it almost like an anniversary. So we have a lot of anniversaries with our patients, because whenever we pass even the 1 year, we congratulate them, we celebrate it with them, because they're always stressed, they're always afraid. So the fact they passed 1 year, 2 years is very important for us. Because as I just told you, still quite a big percentage of our patients don't make it to the 5 years, because I showed you the literature that we had. Before I get into the point of the N0 neck, the comprehensive care, or is called integrated oncology or holistic oncology. These are all different titles for it. It basically includes aspects like exercise, physical activity, nutrition, and psychological well-being. I was not exposed to this until the last 3 years, maybe. In our training, we dismiss this usually. We completely dismiss it. And I'm sure I'm speaking for a lot of surgeons. Right? We want to focus on the procedure. We want to focus on how to do it. We really think that all this is just a waste of our time. It's alternative medicine, but this is not alternative medicine. I will just say the point now. This is actually called integrated or holistic oncology. It's incorporating these different facts. I cannot pass it because I'm sure there's surgeons in the audience. I was just like you, completely dismissive of this. We really thought it has no value. And this is for someone else, not for us. The World Cancer Research Fund, I really have a lot to talk about in this area. I don't have time to present it today. I just want to give you glimpses of it. 40% of cancers can be prevented by just changes in these aspects. Don't think about it as a number. Think about it of 40%, I don't know, what's 40% of cancer patients in Indonesia? I don't know what's the number. That's, I don't know what is it, but let's say 100,000 family that will be saved the suffering of cancer and its consequences, whether cost-wise, loss of family member, so many aspects that oncology can affect. So don't think about it as a number. Okay, this is very serious. The fact that 40% will be spared is very serious. The French National Cancer Institute found something similar. Cancer Journal in 2008. This literature is there for a very long time. It's nothing new. 68% decreased mortality in breast carcinoma. I'm sure you're familiar with this. There's one famous paper about breast cancer patients. I remember the name because it's named Dr. Spiegel. He was a surgeon, and he was completely dismissive of these concepts to breast cancer patients. He said it doesn't matter. They go to a support group or not, it doesn't matter. They have some psychological well-being, it doesn't matter. It's surgery, radiation, chemotherapy, that's what matters. And the paper that he did proved the opposite. That's why it's very famous in the field. So I don't have time to talk about it, but I'll just tell you two more things. It's actually, we all know pathophysiology, right? We know that term. But there's another term. I don't know how many people are familiar with it. I just learned it, as I said, the last 3 years maybe, excuse me. Psychoneuroimmunology. We know each one of them, right? You know psychology, you know immunology, you know, what's the third one? Endocrinology, right? Neurology, psychology, and immunology. You know each one of them. But each one of them is connected. If the patient's psychological well-being is affected, their immunity is being affected, their ability to fight cancer is affected. That's just put it in very simple terms. I wrote with a group of people this book a couple of years ago. I don't have time. It will take, as a workshop, it takes 6-7 hours to go over it. But anyone who's interested, please send me an email. I will send you the manual for it. It have all the information. It basically goes through an introduction. It's focused on oral head and neck cancer. However, the information in it is general for any cancer patient. So it goes through an introduction of this concept. It goes through the psychological well-being, the nutrition specifically, how it affects, and the history of it, and finally the physical activity. How much time I have, Professor? How much time I have? I don't want to really take long. You know? No, please. Someone just moved their head like this. I'm kidding. No one did that. But you know, for us we're keen, but for the students, they're in classrooms all the time. So anyhow, I'll talk about this briefly. Those who are not specialized in the field, don't take it as information that doesn't matter to you. Take it as knowing how each profession can advance. There's something in our field called N0 neck, basically oral cancer with no nodal disease. What to do with them? How should we approach them? This is a very old topic that we discussed for a very long time. And it went through, like everything in medicine, it goes through different options. So think of this as how we're seeing things advance. We talked about salivary gland a couple of days ago, and we change our practice sometimes. So this is important for everyone, because most of us really like and respect our professors. We learned something in a certain way, and we never change. We get just focused on doing it the same way. We never change the way we do it, even though the literature supports it. So we all know in oral cancer we used to have this, basically, radical neck dissection, which is done for everyone. No one does that anymore. For everyone. We do it for indicated cases. Then we moved up to modified radical. Even that is not necessary. Now we do selective neck dissection. Then we started assessing the tumor grade. Is it poorly differentiated, well differentiated, and so on. And some risk features. What was the most important aspect in the past decade, let's say, 2 decades, was what we call depth of invasion. How deep is the invasion of the tumor into the connective tissue? And if it's deep enough, we can consider doing the neck dissection. And now we have different approaches, different schools. We either do elective neck dissection, as I will talk about it in a second. Almost everyone will have, in oral cancer, almost everyone is getting a neck dissection. Squamous cell carcinoma, I'm talking, not salivary glands. And because of that, this is just one slide that we talked about a couple of days with those who were not here. This is a very important slide, I guess, in salivary gland cancer. because in salivary gland cancer, we don't do it for everyone, as I said, in squamous cell. We almost do it for everyone in squamous cell carcinoma. But in salivary glands, it depends on the entity of the disease. In salivary gland, we have so many different variants of tumors and very different variants of grading, and each one of them makes a difference. So even this cribriform adenocarcinoma is a low-grade malignancy, but have 60% chance of going into the neck node. So definitely neck dissection has to be done. But when we go now to oral cancer, excuse me. Yeah, I'm going to skip this. As I said, now the discussion, the really big discussion, which been the controversy in conferences over the past couple of maybe decades, is whether to do elective neck dissection even though we don't see the nodes, or just observe the patient and follow up. So it started with papers in 2014 saying there's no difference. This is a very famous paper saying that there's no difference whether you did observation or elective neck dissection. So what will most people do when they read this paper or see that recommendation? They will do observation. No one will do the surgery because it's the same. However, when you go deep into the paper, which is important in any profession, you will find that the majority of patients were T1. 85% of the tumors were T1 tumors. And of course, T1 doesn't behave like the rest of the tumors, so that is not necessary there at all. So even in that subset of paper, when you go back and exclude the T1 tumors, actually it showed a difference. Another paper in 2015, it favored elective neck dissection, excuse me. So, and this oral oncology journal, so one of the probably the most significant journal in oral oncology. There's other cancer journals very important, but in oral oncology, this is probably one of the top, that and head and neck. So again, it showed significant advantage to elective neck dissection. One of the key papers that almost made a conclusive answer, for which now we do elective neck dissection for almost every oral cancer patient, squamous cell carcinoma, was this paper in 2015 in the New England Journal of Medicine out of Tata University in India. It basically showed significant improvement in survival when neck dissection is included, regardless of the depth of invasion. Because as I said, the other school, which is very important, is focusing on the depth of invasion. If it's 3 or 4 millimeter, then you go ahead and do the neck dissection. But this paper showed no difference. Even when they included that in the multivariate analysis, there was still an advantage of including the neck dissection. So there's limited availability or applicability of the depth of invasion here. And if you allow me, please, Professor, I'll just ask a question, maybe just to break down the lecture, maybe people get their attention a little bit. Why do you think, especially maxillofacial, ENT, head and neck, why do you think depth of invasion in the biopsy of oral cancer have limited applicability? Just to think about it a little bit, even if you didn't get the right answer or it's not your field, just to get you thinking about it. The point is you all know the cancer, you all saw cancer, right? If I took a biopsy from the posterior aspect of the lesion and it showed a 2 millimeter depth of invasion, who is to say the anterior extent of the lesion doesn't have 4 or 5 millimeter depth of invasion? So that's just one factor for which it's limited. It doesn't really give us a final conclusive answer. 2010, 2019, 2020, 2024, this is a randomized clinical trial, over 1,800 patients. Significant improvement. It was the top treatment option. So each time you update, even just to conclude between the two guidelines, so basically the American guidelines, the Journal of American Medical Association, almost elective neck dissection is done in the majority of patients. T2, T3, T4, definitely. In the Tata paper, even T1 if it's in the tongue, floor of the mouth or cheek, which is the majority of patients. So that leaves us with the alveolar squamous cell carcinoma, or superficial invasive, that is 1 millimeter. So very limited areas that doesn't have that to be applied to. That was basically, I just went through the papers quickly. Obviously, gene expression was very important. I thought by this time, because when I was in your seats, gene expression was a big thing, and everyone was talking about it, and we were hoping it will change the way, I guess in breast cancer it's there's something called the mama print, but in oral cancer, we don't have that yet. So until now we don't have anything, so I'm really not gonna talk about the papers, because we're just not there yet. I think biomarkers, or AI might supersede gene expression. I'm gonna really just go over the paper. I'm not gonna discuss the papers, but these are papers discussing that. I'll be glad to share it later on with anyone who's interested. But so just some different biomarkers. But when I say AI, I think that what seems to be the highlight in the literature now is how AI can apply to imaging. How can analyzing the imaging can give us a predictability of the nodal metastasis. So we decide to do the neck dissection if it was high likelihood on the imaging. So that's where I think the future might be for us. Different papers on that use of the AI. So really, at the end, basically, again, I would like to thank you all for being here. Thank you, professors, for the invitation. Really appreciate the opportunity. And good luck to you all in your training. Thank you so much.
Thank you very much for a wonderful lecture. So we move on to the Q&A session. Do we still have any questions from the floors? If you have any questions, just raise your hands. Maybe, yeah, please.
Ya, Assalamualaikum warahmatullahi wabarakatuh. I'm president of oral medicines. I will ask to Professor Basem T. Jamal. My question is, how's development oral squamous carcinoma cell cases in Saudi, and what is the main contributing factor in Saudi? You say that tobacco, alcoholic and smokeless tobacco, and are they used in there? And is there any correlation in Indonesian cases? Maybe
Thank you.
that's it.
So the question was regarding the risk factors in Saudi Arabia for oral cancer, right? What was the first question? I'm sorry.
Yes, sir.
The first question.
How's the development oral squamous carcinoma cell in cases in Saudi?
Yeah, good point. So cases don't always start as oral cancer, right? That's the first point. Sometimes we have changes, mucosal changes, that have higher likelihood of transforming into cancer. Specifically the dysplasias and the proliferative verrucous leukoplakias and some other entities that have a risk of developing later on into cancer. So that's the first point. So not all cases develop into cancer immediately, but sometimes white lesions or lesions in the oral cavity, white and red lesions have even higher risk. So whenever you evaluate any patient who have that, special attention have to be paid to them and close follow-up. Some patients do have oral cancer up front. Sometimes trauma, repetitive trauma to the area is definitely a risk factor. So the fact that the patient might be biting their tongue regularly or have even any dental work that's injuring the tongue or the cheek regularly, that's a risk factor. So don't underestimate taking care of that very quickly for even of any family member. So that's regarding the risk factors. Smoking, definitely the top we know. Smokeless tobacco even higher, but not a lot of people use it. But I just want to emphasize again, we know the cause of 30–40% of cancers. Most of the other cancers we don't have an explanation for it. The patient is fit and healthy and no family history, no smoking history. It relates to these other factors which we talked about, this integrated concepts, because you all know about epigenetics. So the environment, the food, the physical activity, all that can affect the triggers in the genes that will lead to cancer later on. So I guess I was talking in the OR about some of the food traditions shared. One of the areas we have high nasopharyngeal cancer. They have very high use of salted fish. I don't know what is it called here. Salted fish. We have a name for it. So the fish that's preserved in salt. This is associated. That region have much higher nasopharyngeal carcinoma in our country. And the region that have the use of the smokeless tobacco have very high likelihood of oral cancer as well. So each region has its own factors that might increase the risk factor.
Yeah, very interesting. Environment really affect the risk of cancer.
Yes.
Okay, is there any other questions? Okay, maybe the last from me probably. Sure. I'm not a surgeon actually, so I was surprised to see the very low survivability of oral cancer. And currently, do we have kind of way to detect this cancer earlier, or do we have kind of like BRCA1 for breast cancer, so very early to detect and we can prevent this cancer?
Right. Yeah, great question, because that's how we should be thinking, all of us really. What can we do to diagnose it early? Unfortunately, nothing like clinical exam. We don't have anything yet. Again, I was hopeful that by this time in the practice, I'll have a blood test I will send the patient for, or some kind of, special easy tool like an iPhone. We point it and it tells us what's happening. Until now, I even did research on the light, fluorescence light. Nothing picked up to an extent to become applicable and easy to use and affordable to be in our clinics. So nothing is there except the, clinical examination and understanding risk features. So patients who have a high risk feature profile, they should be really asked to follow up closely. And there's a very famous paper in 2005 in the Lancet. They did this, they call it high risk, basically features, and they focused on those group of patients. Whoever have these criteria will follow up in the clinic every few months. And they found that they decreased the mortality of oral cancer by, I believe, 32%. Again, don't take it as a number. I think when we looked at it, it was 40,000 lives saved every year. Just by doing clinical exam, nothing fancy, no fancy tool, no fancy technology. If every place in the world applied that clinical exam for their high-risk patients, 40,000 patients would have been saved from even developing oral cancer. So yeah, until now, nothing, unfortunately.
Okay, thank you very much for your lecture. It's Muhadara Mumtaza.
Thank you so much.
An excellent lecture. So just give a round of applause. And we are coming to the end of the sessions. So once again, thank you very much for all of you. Thank you for Professor Rina and Professor Prihantono for hosting the sessions, and also thank you for Professor Basem to give an excellent lectures.
I would like also to emphasize something really, because we've been doing these camps for the past maybe 7–8 years. So none of this would have been possible. I know Prof. Pri sees me in front of him, and I talk with him all the time. But we couldn't have done any of this without the support of King Salman Center for the Relief and the Muslim World League, which between the two of them, each one have their own area of expertise. And really, we see it in different places we've been to. The amount of support we have to be able to do what we're doing couldn't have really been done without their very, very amazing support. They're always around the medical team, I know they're behind the scene. You don't know them. They're sitting with us. You don't know them. You see us. But we couldn't have done anything without really the support of our admin staff, the admin managers of the course, and the foundations. So please, I would like to thank them. I would like you to thank them as well.
Thank you very much. Okay, the last sessions we're gonna give a certificate and souvenir. So we invite kindly Professor Rina to give a souvenir and a certificate for our speaker. All right. Thank you very much, and hopefully it's not the end. Hopefully we can see you again next time. And bye-bye. Thank you.